Welcome, council members and those listening in. I hope everybody had a very nice Thanksgiving and is looking forward to a good, hopefully, holiday season. We are going to begin with the minutes of the last meeting, and I am going to ask, is there any discussion on the minutes? Then do I have someone who is going to propose approval?
So moved.
Thank you. Thank you. You're first and second. I need to do this as a roll call, so let me hope I get this right. Laura Adams, yay or nay?
Yay.
Okay. Rob Birmingham.
Yay.
Good. Where am I next? Sandy.
Yay.
Great. Meredith.
Yay.
Thank you. Lauren Peters.
Yay.
Great. And Cassandra.
Yay.
Great. Niels.
Yay.
Great. And David.
Yes.
Terrific. Then the minutes of the last meeting are approved. I don't think I skipped anybody. Please wave your hand or do something frantic if I did. Great. Terrific. I'm going to turn the agenda over to you, Ray.
Thank you so much, Chair Donahue. Welcome, members of the Oversight Council. Looking forward very much to today's presentation and discussion. Thank you for taking the time to join us. I think you'll find that we've got some interesting things teed up for you. Why don't we start in with the slide deck? If we could go into presentation mode. All right. And next slide, please. Having approved the minutes, we're going to do the executive director's report. The other items on the agenda for today are a presentation, an update and demonstration on the enhanced APCD project, which has really reached a milestone in its development, or essentially the end of development and the beginning of operations. So we're very excited about that. And then discussion, or really an ongoing discussion about CHIA's analytic agenda with roughly a 2-year timeframe horizon. Okay, next slide, please. So starting out with the executive director's report, first a finance update. We're kind of, next slide, please. And then I'll talk about the APCD and some performance metrics for the year. We're kind of midstream on fiscal year 22. And so there isn't that much to report on FY22, but at our last meeting, there was a request that we put CHIA's FY22 spending into some context, some historical context, by comparing it to some prior, there wasn't specified, what the prior year would be, but in thinking about it, having just come through the CHIRTF cycle, it's an unusual, our finances have been quite unusual each year. So at least for purposes of this presentation, I picked the year immediately prior to the start of CHIA's payments to the Community Hospital Reinvestment Trust Funds. This is sort of the last year before those payments began, and fiscal 22 is the first year after those payments ended. So this is really kind of the bookends, if you will, on CHIA's Chapter 115 obligations. And so what you can see in looking at it is that it hasn't changed dramatically. There's a lot of aspects of our spending that have been very stable. So I guess probably among the biggest differences, so payroll is the largest component as it was then. It's somewhat more, it's a slightly larger share of CHIA's total spending on the right-hand side than it was on the left, and it's also up the most by about $3 million. Elsewhere, you'll see kind of the numbers are much more stable. So all other spending, which is, or let me get to that last because that's all other. Aside from payroll, CHIA's largest expense item is non-payroll IT expenditures. This is the cost of what used to be our data center. Now it's our cloud contracts and various things related to CHIA's IT infrastructure, actual hardware acquisition costs, but other things as well. You can see that it was 7.9 million in fiscal 16. It's now 7.6 million, so down slightly. Kind of going up the chart, debt service is a new item in CHIA's budget. That's because as we've worked to pay $45 million into the Community Hospital Reinvestment Trust Fund, as we've discussed here at this Oversight Council, CHIA has used or has worked with the administration to use a certain amount of agency funded capital as part of our solution for making those payments. the payments themselves are not using capital funds, but just CHIA had capital eligible expenditures that we had not been using capital for. So anyway, with that comes some debt service obligations. So you see $2 million in debt service that we have in fiscal 22 that we did not have in fiscal 16. Consultant spending is down slightly from fiscal 16 to fiscal 22, from 2.2 million to 2.1 million. And then all other spending is up very slightly from 2.9 million in fiscal 16 to 3 million in fiscal 22. So as I said, overall, kind of the major pieces are stable. Oh, I'm sorry, I didn't mention the red slice on the left, reversions, 3 million, there was no debt service in fiscal 16. So one difference between the two charts is the chart on the right has a debt service component that didn't exist in fiscal 16. The chart on the left shows that in that year, CHIA reverted $3 million. And that means we underspent our appropriation by $3 million. So that shows up in the chart on the left. We do not anticipate any significant reversions in fiscal 22. So that's one, kind of, as I said, one way of comparing CHIA is by looking at that fiscal 16 year prior to TURDF. I will say also within these categories, however, and it was over that period of time, there was quite a bit of activity, really. The CHIA's spending dropped sharply in fiscal 17 and 18, and then it has been kind of rebuilt over the last couple of fiscal years. So that's, kind of not reflected, obviously, in this kind of this point-to-point comparison. And then, of course, CHIA actually has pretty significantly shifted its focus there's a lot of IT emphasis, and I'd say this not to be pejorative, but there was, I think there was kind of an IT-centric mindset when I arrived at CHIA. We have great IT folks, but we're really characterize ourselves now more as a data operations and analytics agency. And so we do a lot of data operations, a lot of analytics. We've shifted a lot of our personnel to reflect that. And so these high-level categories don't capture that. Anyway, I want to stop there, ask if there are any questions about CHIA's, just this snapshot summary or comparison of those two fiscal years.
Any comments, or I'm going to comment about where we are in the process going forward. Just remind us.
Of the budget process going forward? Yes, so the fiscal 23, and actually one thing we are looking to do is to kind of restart and reinvigorate the Administration and Finance Subcommittee that CHIA has, but as a result of all the sort of oddities brought about by the TURDF process, we haven't always, haven't always been using the Administration and Finance Subcommittee. We want to restart that, but tie it to times during the budget calendar that make the most sense. We've looked at what the HPC does. We're looking at some other independent authorities so that we can tie in the Oversight Council's involvement in the budget process at the right points in time. So for fiscal 23 going forward, we're waiting to hear from the administration on the level of funding they're willing to support for CHIA in fiscal 23. So we don't know. We've shared with them kind of an estimate of CHIA's resource needs for 23, but still haven't had any discussions. I think it's obviously because there's a whole lot going on between, just a lot of extraordinary events with the pandemic and other things. So we've been sitting tight waiting to hear. So I guess I would say it hasn't really kicked off yet. But after the administration, of course, the House and Senate process will start after the first of the year. So very soon, certainly by the next meeting, we'll be in the thick of it. But at this point, we're still waiting.
Great, thank you.
Okay, great. Well, then let's move on. So next slide. And it just occurred to me, since I did show kind of our spending, that it probably was incumbent on me to at least, I guess, make the case at least a little bit briefly for, why I think this funding is important. And I've said in other settings, and probably this group at other times, healthcare, I think, is the most important industry in Massachusetts. There are other industries that rival it in size, but healthcare is what provides our healthcare. And healthcare is also an industry that hits every individual, family, business, and government budget in the Commonwealth. So it's an extremely important industry. And I would say, apropos of the first point that I have up on this screen, it's never been more important than it is right now to have good data about the Massachusetts healthcare system. And fundamentally, that's what CHIA does. We measure the Massachusetts healthcare system to support better public policy. And in light of everything that's happened over the last 2 years, and frankly, in light of everything that's going to be happening over the next 2 years, as I said, I don't think it's ever been more important that we have good data about our healthcare system. Just as a comparator, if you will, the prior slide spanned 7 fiscal years, fiscal 16 to fiscal 22 is 7 years inclusive. Over that period of time, CHIA's budget was up 1.9 million, which is a little less than 7%, which is a little less than 1% per year. During the 7 most recent years that CHIA has THCE data, the Massachusetts healthcare system increased in size by $13.6 billion, or about 27%, much of which comes from the taxpayers. So I think the point I'm making is that we recognize the burden that we place on our assessees. We appreciate greatly the funding that they provide. We recognize the burden we place on the healthcare delivery system with the data submission requests that we impose. But I think in light of the size of the healthcare system in Massachusetts, in light of the importance of the healthcare system in Massachusetts, I think the money that the Commonwealth, and actually, as you'll see the next slide, we're going to talk about assessees, our budget is actually carried by the industry. I think it's money well spent if you put it in context for the size of the system that we're talking about. And then in particular, and we don't have to dwell on these because we're going to talk analytic priorities later on, but if you think about all the issues that are buffeting the healthcare system these days and how much they would all, each of these benefits from having more data and better data, I think that what the Commonwealth spends on CHIA is money very well spent. So the impact of COVID-19, both on residents, but also on the healthcare delivery system itself, the many facets of health equity. We're now seeing continued growth in total healthcare expenditures, and understanding and getting to the bottom of that is very important. There are continuing issues with provider price variation, and that plays out in the resources that are available to different provider organizations that serve different populations in the Commonwealth. So it actually has a tie into health equity. Provider expansion, concentration, and sustainability, certainly in light of the tremendous stresses created by the pandemic. Those are important issues for the Commonwealth to understand and monitor. Utilization and effectiveness of telehealth services is something we've already done a little bit of work on, but in light of its likely continued importance, we think it's something that perhaps like primary care and behavioral health will want to focus specific attention on. Ongoing significant issues with healthcare affordability. It can't be said really often enough or directly enough. This state has affordability problems, and they're significant, and they're getting worse, not better. And then last, and it's really a new issue for CHIA, and we'll talk about this more when we get to the analytic priorities, the cross-cutting importance of healthcare workforce issues. It's really clear that not all, but many of the issues that are challenging the healthcare system today have either at their root or have as part of them a workforce component. And so I think we'll talk a bit more about whether CHIA has a role to play in understanding the workforce issues a bit better. Next slide, please. So this is the last slide of the finance update, but it occurred to me that while I was talking about CHIA's value proposition and our budget, that it would be worth, and I think somebody had asked for some information on CHIA's assessment and assessees. So here's a little information. We have just under 200 assessees. 50% of our assessment is carried by 83 health plans. And then the other 50% is carried essentially by the hospitals, although a little over 0.5% is paid by 54 ambulatory surgical centers. Of the ASCs, the total payments from that entire segment or sector is $200,000. The largest assessment is $15,000 and the median is $2,500. So it's not, and I guess perhaps the subtext of this slide is that these, I think in light of the importance described on the prior slide, these seem like reasonable numbers. In health plans, Blue Cross Blue Shield and Point32 Health pay more than 60% of the health plan assessment because these assessments are based on revenue. So the larger participants in the market are the ones that are paying the overwhelming majority of the costs. So Blue Cross Blue Shield and Point32 Health, more than 60%. And the top 7 health plans in Massachusetts pay 88% of the plan assessments. Switching to the hospital side, the 5 ambulatory medical centers in the state pay about 40% of the hospital total. The 5 largest multi-hospital systems in the state pay 66% of the hospital total. So another reflection of It's the larger institutions that are carrying the lion's share of the costs. Of the 25 hospitals that are not part of these 5 largest systems, the median assessment for those institutions is $143,000. Okay, next slide, please. So this is the last slide of the executive director's report, or my part of it. That was the end of the finance report. Actually, let me pause there. Yeah. Any questions or comments about anything in the finance report? Or maybe let's flip back to the assessment slide. Maybe there's some questions there.
Laura, you're muted.
I do have a question, Ray. It's Laura Adams. Looking at the hospitals, we're seeing 40% of the hospital total and 66% of the hospital total. Can you just tell me a little bit more about that? And then there's 25 others paying a median assessment. It's more than 100%.
No, I'm sorry. I meant they're overlapping categories. So for instance, those 5 AMCs are in the large systems. So those are just sort of different. These are not mutually exclusive categories.
They're not discrete categories. Okay.
Yeah, my apologies. Yes, that is more than yep, that adds up to, too much. Good point. Yes, it's that the 5 AMCs, so the biggest hospitals, without regard to the systems, just the hospitals, those 5 big institutions pay 40% of our hospital assessment. If you look at the big systems, so for instance, Mass General Brigham, it's got academic medical centers, but it also has community hospitals and high public payer community hospitals. So it's, multiple types of institutions. So if you look at the 5 largest systems, which include not just AMCs, but many other things, all other hospital types, that's 66% of the total. So essentially, the larger systems are paying 66% of the assessments. And then just saying of the hospitals that are not in one of these larger systems, either a independent hospital or like a 2 hospital alignment, their average assessment is 143,000.
Thank you. You corrected also. I heard that first as ambulatory medical center, and then now I hear it as academic medical center. So I'm clear. Thank you so much.
And that may very well have been me. My apologies. Thank you.
Any other questions? Looks like you're good to go.
All right, great. Thank you very much. And we can flip to the next slide. So this is my last slide. You're going to be seeing an update and presentation, a demonstration of the APCD, but I did want to just briefly kind of note the significance of the moment, which is that after more than 4 years of effort, the enhanced APCD development project is essentially done. I mean, it's not quite a bright line, but we're going to transfer some data to them within the next 10 days that probably is as good of a endpoint as any. And so really the development is done. We've been testing the system for several months. We're absolutely thrilled. As I say in the slide, I think it's been a resounding success. It's been hard the whole way. Wouldn't have shocked me if this had some significant failure, or if we'd had to give up some big part of the functionality we've been hoping for, but we basically got what we set out to build for the price that was bid. So we're very, very pleased. Anyway, I wanted to recognize the contribution of Deb Scheel and Lori Kavanaugh, who actually left CHIA in 2021 to pursue other opportunities, but really it was their vision, their intelligence, their drive that resulted in bringing the project from before we'd even agreed to do anything, but just sort of advocating for it, and then designing it and carrying it all the way to the point where we were able to have this remarkable accomplishment. So Deb, Lori, the entire team that worked on the project deserves a tremendous amount of credit. We frankly burned a couple people out in the process, I'm sorry to say, but we did achieve something pretty remarkable in the process. I also want to thank our vendor partner, IBM Watson Health, who really stuck in there with us. This was a lot harder than they expected as well, and they stuck with it, and the final results show the level of effort that was made. So anyway, this is going to give us absolutely unprecedented visibility into the Massachusetts healthcare system. And so the challenge now switches to adoption. And so the system now is so raw and complex that there's really only about 2 people at CHIA that can directly access the repository, and they have to be the ones that extract analytically useful cuts that our analysts will use. I'm hoping that by the end of next year, there's going to be 40 people at CHIA and other agencies that are directly accessing the entire claims repository to do analytics, and that by the end of the next year, there'll be around 60. So that's well more than an order of magnitude increase in the number of users and the ease of use. What I refer to in this next line here is the time to analytics is going to be just dramatically shorter than it was in the past. So it's going to open up an entire new range of possibility for analytics that we've never had before. So very excited. You're going to see more about it in a presentation very shortly. Briefly, I'll just mention a couple of productivity metrics because they came to my attention and I just thought I'd pass them along. I've mentioned several times that CHIA has accelerated a number of our data collection activities in response to the pandemic. In terms of what is produced for output, CHIA is going to be producing 42 publications in 2021 compared to 23 publications in 2020. So an 83% increase in the publications we're producing. We're also going to process 279 external data requests, up 50% from the 186 that we processed in 2020. So, and we've recently completed some changes that will allow us to do that much more efficiently. And we are actually expecting many, many more data requests to come as a result of the pandemic. So very excited that things are going so smoothly. And yeah, before I pass it on, I'll pause there. That's the end of the executive director's report. I don't know if there's any other questions for me before I hand it back to the chair.
Your chance to ask Ray anything. I do have a very quick question. With the 2 users today are the 2 at CHIA, and you said it's going to increase to 40. Are these primarily CHIA employees, or what are the other groups within, I assume, state government that will have this access?
It's so hard to pick these numbers. So what I mean by these numbers, we take the APCD and we give it to the HPC, and they certainly have users, but they have to, before they can use it, they actually have a vendor come in and do a whole bunch of enhancements and improvements to it to make it usable for them. So in some ways that's, I'm not counting, they are absolutely users, but that's right now the only people that can go into the actual raw system are essentially 2 high-end CHIA claims data gurus. And the goal is that in the future, there's going to be 25 CHIA analysts. Next year, there'll be 25 CHIA analysts that are on the platform and perhaps 15 at sister agencies. And then the following year, there might be 30 at CHIA and 30 at sister agencies. But right now, in order for anybody to use the system, there's kind of a significant intermediary step of the data having to be, made analytically meaningful for an analyst. And so this will eliminate that, and these people will be native users of the full repository.
So David, I guess that means that the people that you're using to do all this machination on it will not be necessary in the future?
Well, we'll have to earn it. I want to put David, in terms of, that's our goal. That's my hope. But he also doesn't have to do this. We have to be better than what he's got. And that's what we're shooting for. I feel confident though. I feel, because what they're working off of now is our APCD, but it's significantly more limited than what this is. So I think that, I don't know what their transition timeline is, but because they're going to onboard their users while they're still using their other system. So I think the answer is they'll do it in parallel for a while. And then eventually, hopefully, just use our system.
Happy to report back to this group as that process progresses.
Right. No, I'm sure that's a phase in over time and transition for everyone, but I think it's great. And really kudos to everybody who's been working on this. It's terrific.
Thank you. And I really did want to put it out there. That is the acid test, I would say, of success now, is this number of users. It really is all about that. And I can pretty much assure you that the internal numbers will reach what I'm talking about roughly. But I think it's important that we get other agencies to use it, because there is a strong use case, I think, for each agency that the HPC, Mass Health, DPH, the GIC, the connector, and others. There's a lot they could benefit their programs or their policies by understanding the market better, just with this claims data.
So would other organizations, a hospital health plan, for example, be able to use this?
We haven't yet gotten to the point of the idea of native. external users, we would like to. Some of the issues is that the enhancements that are applied to the system are proprietary. So there are groupers that are the intellectual property of third parties, and we're not allowed to distribute them to the world. And so we've paid for us to be able to apply these groupers for our analyses, but there will be some new issues are raised when external users when we try to permission them into the platform. This will certainly allow us to make richer data cuts right away for external users, like Dr. Rosenthal has used as an example. The research that her team, the folks that she works with, they are power users of this claims data. They'll be able to get much richer claims data right off the bat. When they can actually get on the platform, that'll be further down the road.
I think it's an interesting question of who else is led on, how, what are the issues? And certainly as you move forward, something we'd love to be kept up to date on.
Absolutely.
Yeah, actually, quick on that point, Ray, I was wondering, are the 40 and the 60, do you see these more as like goals, or are they kind of like a limit? Like you have like 40 slots that you're giving out, and then 60 slots in 2020, or is that or 2022, or you're shooting to like hit those numbers of users?
Shooting to, like that's an adoption goal. The system should perform well at these numbers and above, and we'll do what it takes to make sure it continues to. If there's happily, if there's a surge of adoption, we'll make sure that that the hardware behind it and the data model supports that many users.
Great, thanks, Ray. And same as everybody else saying, this is amazing. Really great to see you come together.
Yeah. All right. I think that's it. We can have the next slide. All right, I'm sorry. So it's not back to you, Faye. Let me hand it off to Emma for legislative updates.
Yeah.
Thanks, Ray. Great to see you all. I'm just going to quickly walk through a few legislative updates for the council. So we're currently in the 192nd general session. The first year of session just wrapped up, specifically formal sessions ended mid-November. There were a couple of bills that passed of interest to CHIA that I just wanted to highlight. First is an act relative to immediate COVID-19 recovery needs. I'm sure you're all probably familiar with this one. This bill allocates nearly $4 billion in federal funds from the American Rescue Plan Act. It includes a number of healthcare investments, including $250 million to hospitals who were financially impacted by the pandemic. It does briefly mention CHIA and some eligibility requirement language, specifically using our definition for high public payer community hospitals. And then next is an act addressing barriers to care for mental health. This is otherwise known as the Mental Health ABC Act. The Senate passed this last session. It includes a number of reforms for mental health care delivery in Massachusetts, specifically to CHIA. It does require us to measure and incorporate behavioral health expenditures into our annual report process. And then lastly, we have an act enhancing the market review process that was passed by the House last month. That adds additional layers of review and scrutiny to major hospital expansions, so not just mergers and acquisitions. It creates the Health Planning Council led by the HPC, which CHIA will have a seat on. The council is tasked with a lot of things, but namely assessing the healthcare needs and resources in the state and filing a state health plan annually with the legislature. And then just as we kind of look ahead to the next year, the remaining 7 months or so of formal session, we're certainly going to be keeping an eye on what healthcare topics both chambers take up. That's including an anticipated healthcare bill from the governor, as well as bills that maybe passed one chamber last session didn't quite make it to the finish line. So for example, last session, the Senate had passed a bill focused on pharmaceutical costs and transparency. So that's an example of a topic, we'll be closely monitoring. And this is in addition to the 90 bills or so that we track in the legislative process that would have a direct impact on CHIA. Go to the next slide, Alex. All right. And then as I've done in previous council meetings, I'm just going to quickly walk through our publications and data releases since our last meeting in September. So we had released a hospital and health system financial performance reports that includes an annual report for FY20, as well as a quarterly report with data through June 30th, 2021. We also did an update on the provider quality interactive dashboard that had data through 2019. We released another quarterly update to our hospital inpatient discharge data that also had data through June 2021.
Actually, Emma, if I could just jump in there and let the council members know, I mean, just as an example of how much CHIA has accelerated its data reporting or collection reporting activities, the hospital discharge database is something that we used to produce annually. We're now producing it quarterly. And as you saw, we've already produced the data through June of this year, but actually next week we're producing the third quarter that'll run through September 30th of 2021. So it's only going to be the second week of December, and we will have the hospital discharge database through September 30th of this year out already. So that's an example of how much we've accelerated the pace of our collection and reporting activities in response to COVID.
I think that's been a huge improvement. Congrats to the team on that.
Thank you.
Perfect. Thanks for highlighting that, Ray. And then just quickly, we did release a mandated benefit review of a bill and act relative to mental health providers in the 2 latest editions of our newsletter, Data Matters. And then in terms of data assets, we released FY20 outpatient and observation data from our case mix database. So looking ahead to the next few months and some reports and publications that are coming up, again, some additional hospital and health system financial performance reports. We have a new report on healthcare equity coming with a focus on demographic characteristics. Another quarterly update to the hospital inpatient discharge data that Ray had just mentioned, as well as an annual report on FY19 outpatient observation and discharge data, and a hospital-wide adult all-payer readmissions in Massachusetts, another report on that, and then a study on continuous skilled nursing. And then kind of related to the demographic healthcare equity report, we have one coming out with a lens through geography. And then as well as our annual report on the performance of the Massachusetts healthcare system, our FY20 hospital profiles report, an update on the national healthcare data statistics, as well as the next edition of our newsletter. And then in terms of data assets, we have the annual release of the APCD. We have already shared this data with our sister agencies, and very shortly we will be announcing this, that it will be available for the public as well.
Emma, can you say just one more minute about the skilled nursing study?
Sure. Absolutely. So that is section 24 in chapter 12C. It was added, I believe, in the FY20 budget. It requires that CHIA do a biannual study on the provision of continuous skilled nursing in the Commonwealth. So it looks specifically at, hours authorized versus hours utilized, looks at the wages paid to nurses who perform this continuous skilled nursing. And I'm sure there's other topics as well, but that is, we are aiming to wrap up in January, and that will be our second time doing that report.
Emma, are we looking in any of these reports, that specific of those that have to do with workforce, around availability? Is there anything that we do that measures whether staff positions can be filled?
So that is outside of the scope of this report. I know Ray had mentioned earlier, potentially CHIA delving into some healthcare workforce issues, but in terms of specific availability of nurses, I think that's touched on, but it's not exactly measured in this report. It's more about how wages stack up this industry versus other industries, and compares Massachusetts to other states as well.
There's probably other sources that produce those statistics, but yeah, thank you.
Could you also provide perhaps more information on the new report on health equity and what exactly is going to be in it, both on the demographics and the geography?
Sure, I will do my best. So the healthcare equity report with a focus on demographics, we're aiming to release mid this month. So you'll probably be seeing that very shortly. That looks at, I believe, age, race, ethnicity, and income level, and how that impacts, I think it's access, utilization, and health insurance coverage. And then kind of similarly with the geographic focus, I think it looks at different areas of the state and how it impacts those same kind of issues, again, like access, utilization, and coverage.
So if I could expand on that, excellent summary, Emma, but to expand on that a little bit, the significance of this is that, as we all know, there's not enough data about many of these, really important health equity issues.
Mm-hmm.
One way to get data, and it's not the perfect way, but it's one, and it's a very good way, but it's not perfect, is with surveys. And so CHIA does statewide surveys of households, and we ask for race and ethnicity, we ask for disability status, we ask for all sorts of the things that people would want to know. And then we ask about access to care and affordability and all those things. The problem is when you try to slice it too much. If you want to look at, a particular minority population, you want to look at high income versus low income, the sample size isn't large enough to slice it that finely. And so CHIA has been hamstrung in our ability to sort of dive too deeply using our survey data. So our survey team, very smart people, have worked to combine 3 years or 3 cycles of survey data into a superset of survey data that actually allows us to do these finer slices around these key health equity elements without losing sort of the sufficiently large population sizes for it to be valid. So this is the first time we've ever done it. This is the first state, we're the first state that's ever done this sort of a statewide survey analysis of health equity on this level. So really important stuff. Just a first step. It's going to feed into, lots of stuff going on at the HPC that's going to go well beyond this. But in terms of establishing baseline information, this is a very important study.
Thank you. It's helpful. Anything else from the council members? Great. Thank you, Emma.
All right. Would you like me to introduce the next?
Yes, please. Yep.
Right.
And again, thanks, Emma.
All right. So now I'm going to turn it over immediately to Greg Wheeler and Shirley Wong. You've heard me talk enough about the all payer claims database. They're going to give you an update on the project and also a demonstration or show you the system to give you a better sense of it. So let me hand it off to Greg and Shirley.
Thank you, Ray, and good afternoon, everybody. As Ray said, my name is Greg Wheeler. I'm a senior director here at CHIA. I'm going to provide a bit of an update on the project, some of which Ray touched on, but hopefully I can go into a little more detail. And then my colleague, Shirley Wong, will give some insight into the user experience and examples of the analytic enhancements that come with this product. So Alex, if you could skip ahead, I think 2 slides to the timeline. Thank you. So in terms of the project update, I want to first provide a bird's eye view so that you have some perspective of where we've been, where we are currently in this process, and where we're soon to be headed. So as Ray mentioned, we are at a real milestone transition point from the implementation phase of this project, which is the light blue chevron in this timeline, to the full use and the operations of this product. To get to this point, the team has made incredible progress really since the last time you received an update on this project back in June. The team has completed 5 milestones in that time, on track to wrap the last 2 later this month. And that's a testament both to the work that was put in up front in the previous years to establish a foundation, but it's also a testament, I think, to the resolve of the team to translate that foundation into some tangible progress in completing these milestones and getting the project to a finishing point. So I want to reiterate Ray's thanks and appreciation for our partners, the team at IBM Watson Health, who's really been steadfast throughout, as well as the dozens of CHIA staff who've committed themselves to this project over the years. I think we're all really excited to put a bow on this project, take a deep breath, and then move into actually using the data, which is what we all really come to work for. So it's a really exciting time, and it's an opportune time to give this update to you in December as we transition into operations. Next slide, please. So, over the years, you've been given updates on the objective of this project and the benefits of it. But in the interest just of reiterating it, I think this project really boils down to making the data more accessible for the user community. And the first bullet here really gets at the thrust of why we engaged IBM Watson Health, what we engaged them to help us with. And it was to take our raw data files and transform them into integrated analytic data sources to facilitate analyses. In addition to that, to make the data more accessible, which is also really exciting, is the full suite of analytic tools that users are going to have access to when they get access to the platform. And so these tools really run the gamut for different staff with different capabilities of working with data. And Shirley will talk a little bit about working in these environments. I think another component of this project that's worth acknowledging is around the timeliness of the data that users will have access to. So if you think, our legacy APCD releases are produced just once per year, and they're produced approximately 5 months after the claims run out period. In the new world, we're making the data more timely in two different ways. One is that we're going to be refreshing the data on a quarterly basis. So you don't need to wait a full year before you get access to any type of new information. We can see from last year, when something major happens in the healthcare system, you don't want to have to wait a year or a year and a half until our data is fully baked. Additionally, we've established some improved processes for in working with IBM to process the data that cuts the throughput time from 5 months to 3 months. So I think if my math's right there, that's like a 40% improvement on throughput time. So, in terms of accessibility and timeliness, I just wanted to summarize at a high level the benefits of what we're going to be working with in the months ahead. Next slide, please. I think on that last slide, I mentioned analytic data sources, and it's worth elaborating on what that means a bit, because it does reflect a new way of working with the APCD compared to how users are historically used to working with it. I might have misphrased the first bullet here. I think you can ask as many questions as you want of raw data. I think the challenging part is actually getting answers out of it. With this initial deployment of the APCD, this enhanced APCD, there are 9 data sources that are designed to allow for significantly more rapid and meaningful analysis, both with a business intelligence tool, which is Tableau in this case, as well as the other more detailed programming level tools that I listed on the previous slide. And when I say analyses, I mean that really in the broadest sense of the word. I think a lot of times when we think about the type of work that comes out of analyzing APCD data, we're thinking of these really detailed, challenging research inquiries, econometric style analyses. And the platform is absolutely designed to better support those types of research questions. At the other end of the spectrum are, I would consider more straightforward questions, which are kind of given an example in the green box there, that we've generally struggled to rapidly produce answers on. And it boils down to the inaccessibility of the data. And this is where I think we're going to see the biggest bang for our buck with this product. I think we at CHIA, and I'm sure a number of other organizations who are going to be getting access to the enhanced APCD, have a reservoir of incredibly talented staff who just may not have the detailed programming experience that was needed to work with the APCD back prior to now. And I think we're going to be able to unleash, as Ray alluded to, we have dozens of staff who are ready to take that on right now. And we're interested in working with the other agencies too, to get their staff using the solution. So I've noted there that I think that this will also really help us better align our staff with the types of projects that they're taking on. And our most sophisticated analysts can focus more of their time on these challenging research questions instead of always having to plug into some of these other questions that our larger analyst community will be able to take on. And then one final point about these analytic data sources, we may find in time that there's certain types of questions that are challenging to answer with the data sources that come through with this initial deployment. And the power of what IBM's done for us is behind the scenes, they built this really robust data model upon which these data sources sit. So, general analysts like myself aren't going to need to worry about what's going on in the data model. But what that data model allows us to do is to develop and deploy new data sources over time if we identify the need for that. So, I note that there's 9 data sources here, but that's really just the initial foundation. Next slide, please. So this slide is admittedly pretty detailed, and it's more of a leave behind slide for you to refer back to, but I wanted to list out these data sources just to make them a bit more tangible than what I just kind of outlined on the previous slide. So, each data source has a name, just a summary about kind of what the data source is for, an example use case, which frankly doesn't begin to scratch the surface of what these data sources can be used to do. And then whether we have a data source that will be used primarily for the analysis of the commercial population and or the mass health population. If my math is correct here, the yeses in the right-hand column should total to 9. So that gets you to the 9 data sources. With the exception of the enrollment data sources, which don't include claims, all of these other data sources are going to include incurred claims through December 2020, which it's just worth acknowledging, and of course is a crucial period to make sure is available to users in the initial rollout of this product. And I've added as a footnote here, but I think this is also a real benefit of these data sources. All of these data sources have user-friendly roll-ups that will allow users to stratify their analyses by age groups or market segments or geographic regions. These are things that we might take for granted in the future, but historically have taken work for an analyst to be able to produce analysis by different age groups. So I hope that folks who have used the APCD in the past will appreciate some of them or many of these enhancements. Next slide, please. So my final slide on the project update is just to give you a little bit of insight into the transition period we are. So this is kind of the fuzzy line that I had on my initial slide. On the CHIA side, as we mentioned, we're wrapping the development phase later this month and transitioning into operations. What that really is going to boil down to is how our working relationship changes and improves or becomes more efficient, I should say, with IBM to make it more routine rather than the special initiative that it's been over the years. At the same time, CHIA staff are being trained in the platform. They are performing exploratory analyses, learning really how to best use this platform. And all that they're going to, all that they learn from that process is going to translate into the consulting work that we intend to do with other users outside of CHIA. The first external party that's being brought into the platform is the Health Policy Commission, who's been involved in this project over the years, and in the past few months, staff at both of our agencies have been corresponding on these next steps. So we're doing a lot of work to make sure the analytic environment is set up for the HPC, getting their users credentialed. There's going to be formal trainings and overviews of the documentation and other resources that are available. And I just kind of fleshed this out because I think this isn't just a data set that we're going to hand off and say good luck. Let us know how it goes. This is a really sophisticated platform. There's a learning curve. And we want to be really closely collaborating with the HPC as they become the initial adopter outside of CHIA. At a certain point, I've kind of made this fuzzy too, but the HPC will be hopefully excited to make full use of this platform. When that happens is subject to kind of how all these things go and their availability, but maybe towards the middle or end of Q1 of 2022. That may be a good time for the HPC to really be building out and producing things from this data source. And then finally, we mentioned it a little bit earlier, but we do have plans to bring on other parties as well, both particularly at the state agency level. We'll be in contact with a number of different agencies to start onboarding them. And then I think the world we want to be living in and how others are using the APCD definitely worthy of conversations of how to best bring even more parties in to work with the solution, depending on their needs and what's feasible. So that's what I've got in terms of an update on this. With that, I'm going to turn things over to my colleague Shirley Wong, who is our client services product manager, to give you some additional insight into this great product. Thanks.
Thanks, Greg. I just wanted to thank everybody for attending today, and I wanted to say it's a great pleasure to be speaking to you about the enhanced all-payer claims database. People on this call have heard from leadership already about the potential of this reporting solution. Next slide, please. I wanted to give some perspective from my view as a former analyst who's worked with many of the CHIA data assets, and specifically the Mass Health enrollment and fee-for-service spending data from the all-payer claims database. As Ray touched upon earlier, in the past, our team would depend on one individual to pull the APCD data and transform it in a way where I could easily perform some analyses. And just to repeat, it was one individual who had the expertise to pull the data for the entire team, and I was just one of the analysts on a team of many analysts. Because of these resource constraints, it just wasn't efficient for an analyst to pose a question and then pull the data. So if we wanted to perform some specific analyses on the Mass Health population, a technical specialist would have to pull and link all the enrollment and fee-for-service spending data for Mass Health. If a field was missed in the specifications, the technical specialist would then have to re-pull and relink all the data, setting back the project timeline at least a few weeks. And then afterwards, CHIA had to make difficult decisions whether to refresh the data because of these heavy lifts. So this solution really will change the way that I think about data analyses in the future, and is why I'm really excited about it, because it's going to give me the power to do exploratory analyses without tying down a resource. You'll see that kind of later on in the presentation. This solution, as the slide indicates, already links a lot of our reference data sets. The Tableau data sources allow for quick and timely analyses, and those technical specialists that were tied down with pulling the data for other analysts will now have the bandwidth to do more complex analyses in our Oracle data views. Next slide, please. So you'll probably be wondering now how we're going to access the EAPCD. Our Data and Operations Technology team, or DOT, has worked to provide a solution for users to connect to the IBM solution. Users will be able to open up a browser window and log onto an Azure virtual desktop with CHIA provided login credentials. There will be applications available for use, such as SQL Developer. This solution will also provide efficiency in applying software updates across all virtual machines as they share one image. So that's pretty exciting for our data technology team. And two main ways that the users will access the IBM solution is through Tableau Server or SQL Developer. Individuals, as you're reminded, will also be able to analyze data through R and Python. So next slide, please. So this is what Tableau Server looks like. We have starter templates that IBM has created for us to begin our analyses. So these data sources are the ones that Greg had talked about earlier, ones that can link enrollment and claims data together. In addition, you'll see here, we have some different folders for different users. Here we have CHIA, HPC, and IBM. Analysts can save their work and share with other analysts who have appropriate security permissions. And as we onboard other users, we'll be able to create appropriate environments for those users as well. Next slide. Here, for our more advanced users, analysts will be able to connect to the data through SQL Developer and link data for more detailed analyses. As you can see on the right here, these are a little bit more granular data views. I'd like to spend some time to talk about our analytic enhancements. If we could go to the next slide. We've talked about how we've engaged IBM to help us create a solution that would provide efficiencies in how we pull and link data. But another main reason we've engaged IBM is to provide analytic enhancements on top of these efficiencies. We've included here a few to show to you today. And I just wanted to note that this is data from our user acceptance testing environment, or UAT environment, and represents a subset of our data. So flexible analytics is a set of already tested methodologies provided by IBM, which will enhance our reporting capabilities. For example, IBM's already developed methodologies related to inpatient admissions or outpatient events. This will allow users to perform admission and event level analyses without the expensive processing cost of doing this in-house at all. So for this example, Ashley Storms has created a report using the outpatient event grouper. I want to direct your attention to the folders on the left, where you can see some of the measures and the fields are stored. To the right of that, you'll see a filter chef where we can subset our data. And then to the right of that is where the output is shown. Here, she is displaying median total paid amounts and the number of outpatient events for radiology services for hospitals for 2015 and 2016. I really want to pause here to state that these types of analyses weren't possible in our old system at all. We weren't able to pull outpatient radiology services in this manner. In the past, even pulling down standardized hospital lists, as you see here, was a lift. And as you review this output, I just wanted to remind everybody that this is test data in our UAT environment, which is why the numbers look low. Next slide, please. In much of our work, we link out to different reference data sets, whether that be national data sets to review diagnosis and procedure codes, or Massachusetts-specific ones where we can review mass health coverage types and delivery systems. In our IBM engagement, we've been able to integrate Redbook, a pharmacy drug pricing information database, into our data marts. Previously, when CHIA ran analyses on our pharmacy data, it was a heavy lift for our data operations and technology team to link the data and required an analytics specialist to ensure that the data was linked appropriately. This was a multi-week project spanning multiple CHIA teams. This Tableau report here took me about 15 minutes to create. Here, I'm showing pharmacy data by therapeutic classes, paid amounts, and supply days. And I just wanted to show and state that Tableau also provides flexibility for analysts to create their own measures as well. For example, we could have taken supply days and prescription counts to determine average supply days per prescription. Next slide, please.
I just want to call out what Shirley just said, because it's remarkable. The first time we did this analysis, it was a multi-team effort that took a significant amount of time. I mean, some of it because it was a first-time effort, but nonetheless, the way it was done involved multiple teams, and it was just a very complex project. Shirley, as you said, just did this analysis and replicated that analysis in 2 hours. And so it just, the time to analysis has just been shortened dramatically with this system. Okay, go ahead, Shirley.
Sure. And then I finally kind of wanted to talk about our data quality improvement initiatives. A lasting theme of CHIA is to really strive for continuous quality improvement. In order for this project to be successful, users have to have confidence that the data they're reporting out is accurate. During the development process, we've discussed with IBM the quality rules that IBM will run on the data upon receipt. IBM will then provide us a report so we can identify areas for improvement. In addition, IBM has created a few quality reports that are updated quarterly and available in Tableau, along with the rest of the data in the EAPCD. For example, this Tableau report showing eligibility counts by the 1st, 15th, and last day of the month. Other metrics include percentage differences between previous months. These reports will really help our team determine whether there are any data anomalies. And finally, I just wanted to say that these are just a few enhancements that we're excited about as we move on to operations. There are additional enhancements, including other flexible analytics modules and our information governance catalog, which will provide analysts a data dictionary and source target mapping all in one location. In closing, I really wanted to thank all the individuals who have worked so tirelessly on this project. I really can't emphasize this enough. It's no small feat to work through all of these requirement sessions. And this really takes a lot of thinking upon all of the individuals who have been working on this project. We really probably do some data modeling in our sleep. Their dedication really inspires me every day, and I really thank them for that. And we'll take some questions at this time.
Yeah, I actually had a quick one, Shirley. For your quality control checks, like, are those ongoing? Like each time you get new batches of data, or is that kind of, yeah, yes. Okay. Yeah, that's what that's what I thought when I looked at it. And then just a little bit of a broader question, but I was wondering, like, what level of ongoing support CHIA was planning to kind of like offer for the new application. Like, it looks amazing, but I was just wondering if like somebody has a question or like, you know, further down the line or something like that, like how that's going to look.
So we're definitely going to have ongoing user groups to really work through the data as we're onboarding other state agencies with this. We're also onboarding some of the teams who haven't been really as involved with the APCD project. So I really want to create this user community. And I think CHIA is really dedicated to providing this user community to learn more about the data. I mean, we can really take I feel like I'm pitching this, but like we can really take this very far and we can add in more enhancements. And as healthcare is ever evolving, this solution will ever evolve too with that. And I think we have a lot of opportunity to get feedback from other state agencies who may kind of look at the data a little bit differently and engage IBM in either change requests or other initiatives where we can really make this useful for the time to come.
Excellent. Thank you so much.
Yeah, and Rob, I'll add to that too. You know, there's some IBM is also offering, you know, a lot of support on the routine maintenance of this platform. I think early on, we at CHIA are going to want to probably be the intermediary between other external parties so that you know, the HPC and others don't have to work directly with IBM right away. But at a certain point, I think a lot of the routine support even could just be a helpline through IBM, and other agencies will eventually get comfortable working with them. On the other side of thing, I think is what Shirley alluded to in the user work groups, where we really want to have a community of folks having regular conversations about the platform. So no shortage of opportunities there.
Awesome. Thanks, guys.
Shirley, do I understand this correctly? First of all, I should preface this with this is just terrific. It's really exciting, tons of hard work. It's obvious. Is this sort of a separate sandbox? Is this a duplication of the data that we have? Does it sit behind the CHIA firewall? I mean, I want to understand a little bit about the structure of where this sits vis-a-vis how we house the data within CHIA.
So this data is set up on IBM servers, and we will send data to IBM to house on their servers, where they will create their data model that lives with our data. And then also they'll put enhancements on top of that data.
Okay.
I'm hoping that answers your question.
Laura,
It doesn't. Oh,
sorry. I was gonna say, if I may piggyback, you know, on just for 1 second. And Shirley, I did see that we might be accessing this through the Azure cloud. Like, is that gonna be through our like Office 365 accounts? Like, will that kind of like pass us through the firewall, or just wondering maybe how that would work potentially? And sorry, Laura, if yeah.
So I would have to defer that question to our data operations team, but I can certainly bring that back and ask them specifically about the mechanism of going through the Azure Virtual Desktop. As an end user, I would log on to a secure site where I would then log on to a virtual desktop to access the data.
And I think it'll be the same for all users, CHIA, whether they're CHIA or other agencies. We wanted the user experience to be the same, so it's not, you know, kind of a two-tiered experience. But to your question, Laura, so CHIA still takes, we still do data intake. I mean, one option was we could have outsourced data intake to IBM. We didn't, because we want to have that relationship with the data submitters, because we collect other data from them, and really that working the data back and forth, that's not something we wanted to outsource. That's something that's very important to us. So we get the data, we build the quarterly APCD cuts, and then we ship it off to IBM. And then they do all those enhancements and host 5+ years of data in an online platform. So there's this online, much enhanced version of our data, but we own the data, we own the data model, and we own the we receive the data. So but the data itself, the enhanced version, it's in an IBM cloud.
all right. So it's a version. So data is sent to them. We retain all of it. The complete data set sits here. We send, okay. And then with the enhancements, my next question is, I'm assuming that over time, some of these enhancements are going to increasingly include the development of artificial intelligence and algorithms. And I guess I'm wondering about the work on algorithmic integrity on this, to understand issues of equity, issues of you know, sort of the black box in which those algorithms are developed. Is that part of what we'll be thinking about as we look ahead to what enhancements they may be overlaying on this?
It's a great question. I mean, I think for the first time, CHIA is going to be able to get into types of analyses that you know, raise those sorts of questions. I think that historically what we did was so descriptive that it really wasn't a consideration. I think, and we're about to pivot to the analytic priorities discussion. I think, you know, we're actually starting to, I think, get into areas where we have to be very conscious of those types of considerations. It hasn't been something we've needed to concern ourselves with so far. and not at these early stages. I think our first analyses with the APCD will be very, kind of standard things taken to the next level. But as you'll see when we start talking about analytic priorities, we're now at the point where, right, I think we have to be very conscious of those questions.
Yeah, it's exciting to be at this point because you have to be at a certain level of sophistication to even entertain the idea of doing this sort of thing. So I think it's a huge sign of progress, and it's just again another ramp up in the level of intensity with which we watch how the data are used and make sure that oversight is going on.
Exactly.
Great. Other questions from council members? This is exciting. We've been talking about this for a long time.
Well,
I mean, really, it's been so long and it's literally here now. I'm sorry, David.
no, the HPC was mentioned a few times, so just wanted to chime in and express I think excitement is an understatement, Greg, for us to be able to play in this sandbox, and the collaboration and support between our agencies and over the years in this process has just been outstanding. And that's really a testament to your leadership, Ray, and the leadership of your senior team. And so we're really excited. Everything that Shirley walked through and described as kind of the past versus the future, and the time to analyze, the extenders of staff. We also have, these bandwidth or bottlenecks, I should say, when we look at the data, having to have one person who really has that technical expertise, clean the data or prepare the files or prepare the programming. And so we're just thrilled to take this on. And as I said earlier, we'll report back to this Oversight Council all of our many successes.
Excellent. All right, other questions or comments?
I think that's it, Ray. We look for, are you going to be the one leading our conversation of analytics?
Yes, I am.
Great.
All right, well, thank you very much. Well, thank you very much, Greg and Shirley. Great presentation. And we will, of course, continue keeping you updated on the APCD as we go forward. So, okay, next slide, please. CHIA's analytic agenda. This is a discussion that we started in the spring. It's one of the areas that CHIA statute is specific about the Oversight Council being involved. CHIA's had a lot of change over recent years, and we were kind of moving too quickly in some ways to formalize these discussions, but we're now at a point where these discussions are certainly appropriate and timely. We had a discussion in June that was, I guess I would say, preparatory, another discussion in September, and we're going to take it to the next level here today. So we won't pause or we won't go through this slide. I just put it up because any discussion of CHIA's analytic priorities or analytic agenda really has to start with our data assets, because that's where it all begins. And so a lot of our work is just in the collection and curation of these data assets. They define the types of things that we can and can't do. And so it's worth keeping in mind kind of this foundation that CHIA rests upon, which is these 6 primary data assets. Next slide, please. We also won't take time on this slide. You've seen this before also as part of these discussions, but I wanted to present or to categorize for you folks in some way CHIA's major types of analytic activities. In some sense, these are the types of data we have limit the types of analyses we can do, and sometimes it's just we're limited by what our statute tells us. In other cases, it's probably just more unconscious decision making, and that's why having the Oversight Council look at the analytic agenda is a valuable exercise, because we should be pressed and pressure tested on the types of things we're doing. But this slide just summarizes the types of major analytic activities that CHIA has historically done with its data, and I'm happy to sort of talk about any of them more as we're having our conversation. But as I said, you've seen this slide before. Next slide, please. All right, and I think this is the last one before we actually get to the analytic priorities section. So I just wanted to put it in this context of analytic priorities are very important, but as you heard me say earlier, CHIA is both a data and analytics organization. And so we have priorities that are beyond just our analytic agenda. And this slide lists the 4 that we're, as senior managers at CHIA, keeping focused on as we talk about strategic planning and prioritization. A lot of what we do, as I just said in the prior slide or the slide before about our data assets, is collecting and curating data assets. And so we have priorities related to our data operations that aren't specifically related to that aren't specifically analytic priorities per se. We have analytic priorities, which are highlighted in yellow. That's what this discussion is about. Another enterprise priority is the initial operations phase of the APCD. This used to be the development of the successful development. Now it's an enterprise priority for us to have a strong start for the platform over the next 18 to 24 months. And then we also have, but won't be talking about it here today, priorities over the next 2 years about how we communicate with the outside world. We've got just so much material that we're putting out. I think we need to be very smart and strategic about how we do it. And I think we want to utilize new techniques like video and data storytelling. Okay, next slide, please. Okay, so I guess this summarizes what we had said about, since the spring, CHIA's leadership, and we've been checking in with the Oversight Council as we've been going along. We've been doing kind of a rapid review of potential additions to the agency's analytic workload. We were, very hard pressed during the, the height of the COVID pandemic to just respond to our own work and the work of the demands of the command center. But we perceived that we had a small window where we could, lift our heads up, look around, and decide if there were things that we were missing that we ought to be focusing on. And so this is an exercise we've been doing since the spring, and the Oversight Council along with us. As I mentioned at the September 20th council meeting, we had a discussion. And one of the things we did there is identify several sources of new work for CHIA. At least that's how we go about thinking about it, is to look around and see, what are the needs being generated by, in particular, other state agencies. So the HPC's 2021 healthcare cost trends recommendations, we've looked at very closely for ideas on what we might do to better support their work. Mass Health's Section 115 waiver extension, we've looked at materials summarizing that to try to think through what we can do to better support Mass Health. And we had a laundry list of 17 other ideas that CHIA's managers have surfaced from different conversations and meetings we've been in. So we've continued to work on that list and refine them. Rather than do another long list like that, and rather than give you sort of an accounting of each item that sort of did or didn't make it and why it didn't or what its status is, the next slide just summarizes some of the top items that have sort of come to the top of our thought process or come to the front of the line, either on their merits or just as a result of the outside events. And so here they are. This is the last slide. This is where I'd like us to take some time to discuss, just get people's thoughts on, these are all still ideas under consideration on some levels. I mean, the very first bullet point, I think, is the one that's most certain to happen. I mean, we've already done a data collection cycle on primary care and behavioral health. We're gearing up to do a second collection that would give us 3 full years of data. We haven't done a public report, however, but we are thinking about that and I think planning on that. So this is an area of, and we're not mandated to do those things, but it feels important to enrich the level of understanding about primary care and behavioral health expenditures. And so that's an example of an analytic priority that we're thinking of getting into. Another one, Transparency 2.0. Our first transparency effort was geared around a consumer shopping site called Compare Care. We inherently can't offer a shopping experience because we don't know what a person's out-of-pocket cost will be. Only their health plan can know that. So there were some just structural challenges from the get-go for us offering that sort of a website. But we have a lot that we can do in the area of transparency. And so we want to reboot our transparency agenda. We're going to continue to have the consumer transparency website, Compare Care, but we think there's a lot more we can do with transparency, in particular, emphasizing data storytelling techniques to make our information more accessible to the public without being constrained by the paradigm of a shopping experience. We're looking into developing improved measures for understanding hospital spending. It's clear from listening to HPC meetings and from other things that there's a very strong interest in understanding. We have TME measures for health plans. We have TME measures for medical groups. We don't have comparable measures for hospitals. There's reasons why it's hard to construct them. But CHIA is looking at what we could do to improve measures that we have for understanding hospital spending. Workforce, I've mentioned this previously, but it just seems that this is an issue that is coming up again and again in many different settings. It seems to underline a lot of the different issues in healthcare. Exactly what our role would be is unclear. We've approached this, number one, not wanting to stray out of our lane, not wanting to, duplicate the efforts of anybody else. But it's possible that it would be useful to have someone such as CHIA gather federal and state data specifically relating to the healthcare workforce. And CHIA has data collection relationships with all the major entities in healthcare, hospitals, medical groups, nursing homes, community health centers, and so on. And so it's possible, or at least this is the premise we're exploring, that CHIA could use its, we measure the Massachusetts healthcare system. It seems increasingly clear that measuring the workforce issues in that system is important for understanding and making public policy. So anyway, that's something we're exploring. Measuring commercial and mass health spending, TME at the census block group level is an idea that we continue to explore. Have heard some concerns from the health plans. We will take that very seriously and explore that with them, but this is still an idea that we think is very important. We're looking to leverage, the federal government has now finalized standards that pretty much all electronic health record systems have to have that make it very easy to share certain data elements. And we are looking to understand whether we should incorporate some or all of those so-called US CDI data elements into CHIA's case mix data. We've had some discussions with Mass Health and DPH, and we'll continue those discussions with sister agencies, because really those are the, we build case mix, but others use case mix very extensively. We want to understand if it's something that would be useful to them. And then lastly, and this related to something that had come up, I think when we were talking about the APCD, other states, just in order to get an APCD, they've had to do a lot more. CHIA's been fortunate in so many ways. But in other states, they sometimes it's providers or employers are the driving force behind the all payer claims database. And as a result, its output is very heavily focused on reports that would be of interest to hospitals or of interest to employers. It's a thought that one thing CHIA could do now that we have this wonderful new platform is to generate a whole new type of reports that are geared more towards issues of interest to providers and or employers. So let me stop there. As I said, I think there were 30 some odd ideas at the last discussion. None of them are off the table as such, but these are the ones that seem to have the most interest. And so I just wanted to put them in front of the Oversight Council for any discussion that folks want to have.
Ray, are we talking? Oh, sorry, go ahead.
No, I was recognizing you.
Thanks. I was wondering if under looking at Transparency 2.0, the new public facing data storytelling, are we thinking about the dynamic assembly of data or things that will use more sophisticated displays of it went like this and then it dissolves into that and it shows the trend? Are we talking about that type of graphic storytelling? If so, I think that's super exciting because it's so much more accessible in terms of understanding the gestalt from a data set when we can watch it go from one thing into some. I'll never forget the first time I ever experienced that. It was looking at the opioid crisis and somebody was showing a map of the United States, and as those colors dynamically changed and the red just spread to the whole, it was something I never could have gotten from a static set of numbers.
Exactly right, and that's just what we want to do. And on some levels, we've been aware we wanted to do this. I mean, the New York Times, the Upshot, it's like such rich, gorgeous, visualizations. It's like, who could, not want to be doing that? But also some of it, we had an intern and just sort of having younger people with sort of more familiarity with some of the tools. Turns out that not that long ago, we would have needed to upgrade our website in order to handle some of the types of visualizations we're talking about. There's now add-ons that apparently make that sort of scrolling, that as you turn the scroll wheel, the visuals change and the different text boxes move up and down the screen. That's the type of thing that's now available without us upgrading our website. So we want to start moving into data storytelling because there's so much we've got that I think could grab people. But our first effort was just in this framework of you're shopping for a medical procedure, here's the cost. And that's not actually, I think, what people really want to know about the healthcare system, especially since we can't tell them their cost.
But Ray, you mentioned with this, I think it's great. I'm dividing, I guess, a little bit on transparency. One is the data storytelling. Got it. That's great. But the other is, you said compare care would continue. As is? Is it being used now? What are you thinking about?
It's not really, well, it gets some use, but, and I guess we could look, I think Andrew had given some numbers about it, but it's, because it fundamentally can't show you your costs, it just shows what the provider is being paid. And because
it's old.
And it's old. Yeah, so we're going to update it. Like we even though we think it's highly limited, we don't see any reason that it shouldn't be updated and maybe even improve the interface. I mean, with the proliferation of high deductible health plans, unfortunately, there are more people that are actually shopping full price as opposed to through their health plan. But I think in general, we don't want to be a shopping site, but we want to get that information out there. And so I think we will update Compare Care. That's actually happening very soon.
Okay. And you're thinking more of directing people to their own health plan. If they come on to Compare Care and say, click here if you are a member of Blue Cross or whatever.
Yes, because it's the law in Massachusetts that your health plan has to give you a binding estimate. So it's not really an estimate, a binding, binding estimate of what a procedure will cost you. That's really where you can shop. Yeah. And they also have incentive programs usually.
Yeah. Okay. So that's what those are the two sort of areas you're thinking about for transparency.
Yes, exactly. Yep. And we're also, and other things, we're looking around. Lots of other states have been very active in this area. So one of the things we want to do is survey, and we're talking to the National Association of Health Data Organizations, just copy some best practices. In theory, this APCD should let us, many state transparency websites are driven by their APCD. In theory, we should be able to replicate just about anything we see out there very rapidly. So we're going to just shamelessly crib from other states' transparency websites. And, so we don't quite know everything that'll be in this Transparency 2.0 agenda, but it'll be not constrained by the shopping metaphor.
So kind of actually, Ray, on that point, I was wondering, I've seen, like the city of Boston and Somerville and some other, not sure if the state has one, but they have some pretty cool, and you guys have amazing dashboards as well, but interactive tools on their website. With the new all payer claims database, I was wondering if there's any plans to maybe put together a more of a public facing interactive dashboard or something, or if that's even in the cards. Or
no, it's a great idea, and it's really the way we're increasingly moving. So that I mentioned earlier that we're releasing the hospital discharge database next week for the period through the end of September. In the old days, that would have meant producing a report that summarized, the number of discharges and the number that had this comorbidity and that comorbidity. We've built a dashboard that's got the data through June, and then next week we're going to hit a button and it's going to have data through September. And so increasingly, that's our approach for getting data out into the world, is using dashboards. It's how people want it. And then it's also so much easier for us than producing a full-blown report, although we'll always do reports. But one of the ways we were able to increase our output so much recently has been by using techniques like dashboards rather than printed reports.
More like self-service, kind of like solutions like that direction.
Exactly, yeah. Cool. Yeah, but yeah, the APCD really opens that up, for the potential there. And that's where I said we may want to focus specifically on provider and or employers as important constituencies that we don't always serve as directly. And maybe this is an opportunity to do that.
Great. We had talked a little bit about the workforce issues, and I think most of us, from just I was gathering, I think this is a really important topic. Can you talk a little bit more about what ideas you have in this area?
Well, I think it starts really just with a realization that this seems to be it's a major issue in healthcare, and there doesn't seem to be as much visibility into it as you would like to have. And so there was a recent study that was done by Governor Baker had convened a group, the Massachusetts Healthcare Collaborative, I think, to specifically look at workforce issues. And they worked with a group at the Kennedy School to do a report on healthcare workforce and the pandemic. we want to understand, so there has been some work, and I said, I want to make sure we're not duplicating any effort. But my assumption is that the type of things we do with healthcare expenditure, I mean, this is not that far removed from the types of things we report on. And healthcare expenditures, as opposed to just having a one-time snapshot, we benefit tremendously from having this regular cadence of reporting on the financial condition of the state's provider organizations. It feels like we might benefit from a regular report on employment levels, openings, or the time it takes to fill them, or wage levels, or relative wage levels for staff versus contracted people. I mean, there's so many issues. I think maybe the first step, we've talked internally that we might want to retain a healthcare economist to help us think this through as a first step, because this is slightly different than we tend to look at things. But anyway, this is really just coming from a sense that there isn't enough data out there about these workforce issues. But we also recognize that this is sort of us moving a little bit out of our lane, and we don't want to do that unless it really meets with other people's approval.
Okay.
So are there other state government, are there other things going on in state? Because we haven't reached out yet, for instance, to the Department of Labor and Workforce, Labor and Workforce Development, to understand, what they have in this area. But we're thinking that a healthcare specific report might be helpful. But anyway, I don't know.
Ray, I can just chime in to say that I know Labor and Workforce Development, they've been the sort of convening secretariat of the Healthcare Workforce Collaborative. That there are several secretariats and representatives across agency that are partaking that. So to your point, that is sort of one forum where these conversations are happening. But I will say that the workforce issue is just pervasive throughout, and would, I think having some systematic way of kind of documenting and kind of cataloging where there are gaps in the trends over time would be really valuable, because as we know that there's ARPA funding, there's a whole bunch of, as it relates to our Chapter 257 rate setting process, that is also very much informed, and the workforce questions are a part and parcel of that rate setting process as well. So it's all to say that I don't know that there's sort of one centralized agency or secretariat that's measuring and collecting this systematically right now, but there are several agencies and secretariats that could benefit from this type of data reporting, particularly as it relates to the healthcare sector, because it's, as we all know, the sector probably disproportionately impacted by the pandemic.
Thank you for those comments. Excellent. Yeah, so we think there could very well be a role for us, but we just want to make sure we understand it better.
Yeah, this is a Faye question, I admit. I'm always really curious if at some point we could look into the role of licensing constraints and regulatory constraints on what certain providers could do. And if they were changed, the impact that would have on access and on cost. And I don't know where that would ever come from, but I still think it's a great question.
Well, I mean, the HPC gets into workforce issues, quite a bit with like scope of practice and other things like that. So I think that where there's data, I think they're actually willing to go. And so I think possibly that if CHIA can highlight these issues, it's something that people can start, addressing in a disciplined way. David, I don't know if that's something you want to.
Just to add on to that, I think a lot of support, as the undersecretary said, this is an important issue, but also probably a note of caution that there are a lot of other agencies that are working and thinking in this space. And I would expect private research organizations are also going to be really looking into healthcare workforce. You may not even know this, Ray, but the proposed bill that's on the governor's desk for the ARPA funding does include a healthcare workforce study, examining vacancies, examining initiatives to improve healthcare workforce. And that's something that is charged to us. So, a great opportunity to think about, okay, as I think our agencies work best together is, your agency thinking through how we have the data and the kind of the raw analytics that help feed into policy making, policy recommending, and policy development. And so look forward to working together on that.
Absolutely. And thanks. It's good to know that. And we're also very happy to follow the lead of, like the Attorney General has pioneered things, like did the first foray, and then CHIA takes it on as a sort of an ongoing type of an activity. That was the case with relative price. This could be an example where the HPC does some initial investigation, comes up with a sense of the types of data that would be useful on an ongoing basis for policy making, and then CHIA can start collecting sort of the data, and the HPC would continue on in the policy making role. So yeah, we'll just keep the lines of communication open, and it'll be all good.
Great.
And that's why I say I want to be very careful here, because my sense is that we could easily duplicate or just sort of stray out of our lane, and we don't want to do that. But CHIA does have existing relationships, data collection relationships, like I said, with most of the people you'd want to collect data from to understand these phenomena better, which isn't so much true of some of the other folks, working on the issues. And so it's possible that we could combine our experience with data and analytics and that ability to collect data. But once again, we don't want to duplicate.
Ray, you mentioned that there is concern around collecting data at the census block level. What is the concern?
Just the administrative burden, the level of effort, it's, I think that was the primary.
The level of effort on CHIA, isn't it?
No, I mean, on the data submitters, that we would expect them to do the conversion to submit to us their spending at a much more granular level than they currently do. And so the concern has been expressed that will, be difficult and, burdensome for the data submitters. And we take that objection very seriously. Anytime we hear it, we value the relationship. We feel like we get good data if we're very respectful of the burdens we're imposing. So but we also think this is a really important metric, and the Attorney General, we are always very eager to make sure that we are following through on anything that she's requested. And so, we'll continue those discussions and report back.
Okay.
I'll just weigh in. Ray, thank you for keeping that analytic priority on the list, and for the work that your team has done to explore what more granular TME reporting would look like at the census block level. From speaking from the AG's team, we have derived great value from CHIA's reporting on TME at the zip code level, and have kind of gone as far as we can, I think, with that level of granularity, particularly as we use that data set to try to enhance our own kind of health equity monitoring and reporting. So really appreciate all the work that you and the team have put in and continue to put into scoping out what this will look like going forward.
Thank you for that.
That's great. Thank you.
I want to second that. Just feel like that more and more we're looking at hyperlocal understanding of what's going on, and it really varies, and this is incredibly important work.
Thank you for that. I will definitely say I've been told by my Oversight Council that this is incredibly important.
Great.
Yeah.
Good use of the conversation.
Absolutely.
So, others? Thoughts?
Yeah, actually, Ray, I was wondering, I know you gave a presentation. I think it might have been not the last council meeting, or it might have been a few back, but you were using like a hashing algorithm to like join like multiple different data sets like into like a Department of Public Health warehouse. I really like that project. And I was just wondering, do you guys have anything like that else in the pipeline, or the
Well, I will say we do lots and lots of linking projects.
Yep.
And generally when you link databases, one of the things you can run into privacy problems really quickly. And particularly across domains. Within healthcare, it's one thing, but you try to link a corrections database to a healthcare database, and the lawyers just go into sort of brain lock. And so CHIA's approach of de-identifying data before we take it in because we do public health reporting. We're not serving members. We don't really have to be absolutely, you know, we can have a mistake because we're not going to be dosing medicines or calling the person. And so it turns out that when you de-identify the data, and as long as you're willing to enter into data use agreements that, you know, you bind yourself to not re-identify or do various things, you can get past a whole lot of the legal objections. And so CHIA has a kind of a cottage industry here of linking to the all payer claims database using de-identified data sets. And so the Department of Public Health uses this technique as kind of at the core of their public health data warehouse, which is just a great project. It came out of the Chapter 55 opioid work of combining a bunch of different databases to answer some of the key questions that the governor and legislature wanted to get at. They've now broadened this into an overall public health data warehouse that can answer other questions beyond just opioid related. So it's a neat project, but this capability of linking de-identified data sets is something that CHIA is doing increasingly for other state agencies. And I think even research requests will come in that we're using this capability. So it's, yeah, it's very powerful. Yeah. We can have an offline conversation with sort of more updates or discussions on whatever the latest is.
Yeah, that'd be great, Ray. Yeah, I was just mostly wondering if you know, if there's any kind of like potential like self-service opportunities there. Like, I'm not sure if there's any like common like links that you guys get asked for a lot or anything like that that might be made available. But no, I'd definitely be very happy to talk about this like offline for sure. So
excellent. We will follow up.
Awesome. Thanks, Ray. Yeah.
Yep. I'm sorry, go ahead.
Anything else, council members? Anything you want to add, Ray?
Just that, you know, I mean, what I'd like to do is to, you know, in the future, be able to send out these analytic priority materials further in advance. And my apologies for not being able to do that, because I think it just produces a better discussion. But I'd like to keep the discussion going, because I think that focusing on kind of the, you know, where we have additional bandwidth, where we ought to deploy that is really an important question for the council. And that isn't to say we can't look at the like a zero-based budgeting approach almost, but I think most of our baseline work, you know, is sort of has earned its place. And it's about sort of where we can take on some additional tasks, like what are the highest value areas. So yeah, I enjoyed the conversation, and I hope people are interested to continue to present to you on like what we're thinking about and what we're working on in terms of new analytic efforts.
I think it's been great conversation. It's nice to end the year on all these positives as well, in terms of the work that's being done. So that's terrific.
Yep.
Do I hear a motion to adjourn? It's okay to end early.
Yep.
So moved.
There you go.
Great, thank you. We will adjourn, and I hope everybody has a wonderful holiday season.
Thank you.
Thank you very much. Great to see everyone.
Bye, everybody.
Happy
Bye-bye.
holidays.
Happy holidays.
Bye-bye.
Thank you.